Well, hello, everybody. Good afternoon or good morning, depending on where you are. Thank you for joining us today for our live webinar hosted by ATTAC Consulting. It is called Preparing for Market Changes to Health Equity and Social Determinants of Health. My name is Garrett Schmidt. I'm the managing editor for VBC Exhibit Hall, and so glad you joined us today. A few items of note before we get started. This is a traditional webinar format, so you don't need to worry about muting yourself. We can't hear you, but we do want to hear from you. So we are going to have a Q&A time towards the end of the session today, where you'll be able to ask your questions. So at any time, if you have a question, please submit your question using your control module, and you have a little area for questions there. So it's different than the chat, but go ahead and put your question in there at any time, and we'll get to as many as we can. If we don't get to yours for some reason, because we run out of time, we will definitely make sure to answer you via email afterwards. Finally, we are recording the session today, so afterwards, you'll be receiving an email from us that will have a link to where you can view the recording and also download the slides and connect with the team. And I'll kind of repeat some of this towards the end if anyone's coming later on. So thank you again for joining us. And without further ado, I would like to introduce our moderator, Mr. John Godwald. He is the SVP rather of Sales and Client Services with ATTAC Consulting Group, and he's going to introduce our other speakers today. So welcome, John.
All right, thanks, Garrett. Again, welcome on behalf of everybody at ATTAC Consulting as well as VBC Exhibit Hall. Welcome to our live webinar. So a little bit about ATTAC Consulting Group. We actually turned 20 years old this year. Sometime this year, we're going to turn 20 years old. So we get a gold star, as you can see there. And we're going to be talking today about health equity and SDOH. And you can see on the right side, we also specialize in compliance, auditing, provider network development, operational excellence, and risk adjustment. And most of our clients are in the government program space, mostly managed care health plans. I think over 90% of our clients are health plans. We also have health systems as well. And we also do the exchanges. All right, I'm going to introduce our speakers, my colleagues today. So you're going to get over about 70 years of experience here. We were told we can't do anything past 30, so we can just do 30 plus, just to protect the innocent here. So you're getting about 70 years of experience here. Jennifer Venditti runs our business transformation and technology division, and she's more on the technical side. You can see she's got tons of experience on implementations of IT solutions, technology. She's worked in the product development space, vendor management space, and she will walk you through the first and last part of the deck. And then on the clinical side, we have Lynn Kreifke, who is also a nurse, and she has a plethora of experience, again, 30 plus years in both healthcare and healthcare systems. She's actually going to talk to you a lot of the technical stuff around SDOH and some stuff around compliance as well as pop health. And feel free to ask any questions, like Garrett said, in the control panel box, or the question box in your control panel. Okay, real quick on the agenda, 4 key areas. We're going to talk about health equity and SDOH landscape, how it applies specifically to health plans, and planning for the future. Lots of stuff coming down the pike, as you probably all know. And then lastly, how ATTAC Consulting can help. All right, so we're going to jump right into a polling questions. And hopefully you guys can see the screen here. We are going to start our first polling question. Has your plan developed a health equity strategy, approach, or goals, including SDOH considerations? Okay, see a lot of you are starting to answer. Oh, surprisingly, a lot of yeses. Okay, we got a little bit over half that have voted, so we'll give a little bit more time here so everybody can vote. All right, about 10 more seconds. I know we got a large audience today. All righty, I'm going to close the poll. Okay. So looks like the majority of you said yes. So that's great. So these polling results will be included when Garrett distributes the deck. So we will definitely put those towards the end of the deck. Okay. All right, now I'm going to turn it over to Jen Venditti, and she's going to walk you through the first section, the changing health equity and SDOH landscape.
Hi, everyone. Thank you for joining us today. We're pretty excited to talk about this. This is a lot of what we're either actively working with our partners, or we're involved in conversations because peripherally everything is coming back to health equity and SDOH. Whether we're talking about eligibility data or population health initiatives or different kinds of member experience and care coordination activities. So we're finding that there's lots of activity. It's to be honest, it's not terribly surprising that so many folks have started something with regard to health equity and SDOH. And what we really hope to do is kind of level set and put some ideas forward in terms of next steps and how you may be able to help foster your development and execution of whatever plans you have in place, or if you're just starting out, how you can really get going with them. So we're going to start with some level setting on just where we're at with health equity and SDOH, and then talk about all the different things that are happening out there. As we all know, there's lots and lots happening. So first, we wanted to level set, and we're leveraging the Healthy People 2030 definitions here and some of the references. We find that the Healthy People 2030 is a good place to start, and what it helps to do is align across all the different initiatives that are out there, because everybody does have their own definitions. So NCQA, HEDIS, CMS, individual states, different plans may have their own approach, and so what we're trying to do here really is get to a level set. So from a health equity perspective, everybody's goal is to achieve the highest level of health for individual people. So it's at that aggregate level, but it also goes down to the individual person level, which we're finding more and more across the board. So it aligns very well with other goals and strategic priorities that are happening from a clinical population health care management perspective. That balance between the aggregate and making sure that individuals still are represented appropriately. The next piece is we talk about health disparity, and this is where really the health disparities are what's preventing us from getting to health equity. And what we find is that the health disparities that have been identified over the course of particularly the last several years, although this is not new news to any of us, results in either lack of access, results in higher complexity of medical issues or behavioral issues or both, and potentially lower life expectancy or all of the above. And so what we're really trying to do is address health disparities as it relates to achieving health equity. And one of the biggest pieces is the social determinants of health, or SDOH. And again, from a Healthy People 2030 perspective, there are 5 primary domains of SDOH. This, it cuts across all the other definitions of SDOH, although every stakeholder who's looking for reports or outcomes from an SDOH and health equity perspective may have their own way that they're looking at it. There really are these 5 domains listed on the bottom right here: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social community and context. Now, while those are the domains, there are a whole host of individual fields or ways that you can measure this. There are also adjunct ways to approach things that are fields that can help you monitor and measure your success and outcomes. But we felt that this picture, and again, I don't like to read the pages, so we felt that this can help level set and make sure that we're all on the same page, especially since, as I said, every stakeholder entity group has their own approach to looking at these important terms. Next page, John. So the underlying issue that we have, of course, is, how does SDOH and health equity fit together from a health disparity perspective as well as overall perspective? So for here, we pulled some information from the National Institute of Health, which we think is a really good approach. And it focuses on the life course. And the life course perspective recognizes that each stage of life is influenced by all the life stages that precede it, and in turn, influences all the life stages that follow it. So what happens basically is, from a birth outcomes perspective, all the way through the course of your life and even beyond to generations in the future, your, in particular, SDOH status can influence not only your own, but also your generational relatives' health equity. And what we're trying to do is really break down those barriers so that we can eliminate those to whatever extent possible. So this is the first of the kind of where are we at, how did we get here, and then we'll talk some specific about the new initiatives that are underway. So what's been happening over the last few years, and it's not, again, not new, but lots more has been publicized and lots more studies have been undertaken. So in essence, disparities have been found to adversely affect health outcomes. SDOH can also impact health outcomes. And really what we find from a market perspective is that Medicaid was the earliest adopter. I think probably because of the markets that it's serving from a population perspective, but Medicaid plans in general wound up starting to see more and more of the impacts of SDOH and challenges with health equity by default because of that population. And so lots of Medicaid plans, even though they may not have called it health equity or SDOH, they're addressing these continuously through either state-sponsored initiatives or initiatives in response to their own population challenges. Shortly after, the SNP populations, again, not surprising because of the population itself, started to see the same trends, started to be able to address some of these issues. And while they're calling it, whether they're calling it health equity strategies and solutions, or they're just trying to tackle it through benefits and services that they offer and trying to improve the lives of their membership population, it's still all related to the same goal of health equity and making sure that those barriers are broken down that's preventing it. What's happening more and more recently is that Medicare Advantage, Marketplace, and commercial plans are starting to see the same kind of activity because, in part, some of the impacts that different Medicaid and SNP plans have had, as well as continuing to evolve into that more population health and really outcome-centric that balance the aggregate as well as the individual. So lots more pushing along towards the Medicare space and then even into, like we said, commercial and marketplace products. And what's happening right now is every time we turn around, we're getting new and improved and, sometimes even we would say unreasonable expectations in terms of health equity and SDOH from a federal, state accreditation requirements. And so what's happening there, especially for plans who have more than one market offering in any given region or even across regions, you've got to make sure that you've got a plan that addresses all the various moving parts and pieces. Next page, John. So when we talk about priorities and new requirements, we're going to start the outer circle here is our representation of, at a minimum level, the different types of new requirements that are happening. And in the center are really the priorities that are being identified and need to be addressed from a health plan perspective. So first off, from a HEDIS perspective, there are new measures that are going to require or are requiring stratification by race and ethnicity. We also know that there are more gender relevant care measures that are coming in, and we expect HEDIS measures to continue to evolve and to continue to require more of the SDOH focus so that you're demonstrating outcomes to those neediest members and populations and really making sure that you're addressing across your entire population. From an NCQA perspective, there is a fairly new health equity accreditation at 2 different levels, health equity and health equity plus. And really that is all about community and social risk factors and scoring against your population. From a state perspective, there are at least 10 states that we know of that are considering bills related to collecting data and reporting out data regarding health disparities. And so, from a state perspective, whether you're in the commercial, the marketplace, or in a Medicaid program or DSNP program, there are more and more requirements that are coming out from an SDOH and health equity perspective. The newest VBID from a CMS perspective, all VBID plans as of 2024 will be required to include a specific health equity plan. So that is new, and plans that are looking to do VBID, which many Medicare Advantage plans are looking at VBID. You are going to have health equity plans as part of what you deliver. And then lastly, the CMS proposed health equity index, which continues to be proposed but is moving forward, and we're envisioning that it is going to be finalized because it just pushed, I believe it was last week, it pushed forward to the next level. And what's happening there is they are changing the health equity index measures so that subsets of enrollees with specified social risk factors are going to be monitored differently, which will impact your risk adjustment process going forward. And this new health equity index is expected to replace the current reward factor for star ratings. So that will definitely impact from a fiscal perspective, where a lot of these are more outcomes related, may not be fiscal, but from a CMS perspective, there will be a fiscal impact directly. John, I'm going to turn it over to you for the next polling question.
All right, thanks, Jen. All right, so the next polling question. What challenges are your plan experiencing around health equity and SDOH? And please select all that apply. All right, started off slow, but looks like people are starting to getting the vote going. We were going to put all the above, but we figured it'd be better just to use the select all that apply feature. Okay, a little over half have voted, so I'll give a little bit more time. Okay, about 10 more seconds and we'll close the poll. All right. So the poll is closed and it looks like we got a pretty even distribution except for the one in the middle around designing benefits and services. So it looks like a pretty equal distribution, which would be expected considering the territory that we are in. Alrighty, once again, these polling results will be included with the deck when again sends out. So I will close the poll and I'm going to turn it over to Lynn, and she's going to talk about the key considerations for health plans. Lynn?
Thank you, John. Thank you, John.
Absolutely.
Next slide, please. So what are some health plan concerns and risks? Reducing health disparities, as we know, is a formidable task. The social determinants of health is one strategy being utilized to address the disparities. Health plan members at risk for healthcare non-compliance due to transportation, for example, can be potentially remedied with a ride to the doctor. Unfortunately, we all know these issues are much more complex. Accreditation in some states are requiring a quality strategy to address health equity and individual member needs. Collection of race, ethnicity, and language is key to implementing a strategy. We found that obtaining this data wasn't easy, honestly. Race, for example, is frequently incomplete. Data source values vary depending on the standard you are using, be it NCQA and or CMS. Member engagement has become much more difficult since the pandemic. Preventative visits still are not up to pre-COVID rates. New methods must be employed to encourage members' participation in their own healthcare. We offered members nurse practitioner visits, for example, for preventative care and immunizations at our health plan. Unfortunately, this was not well received by our membership. Development of incentive programs such as offering a gift card for compliance with childhood immunizations was a much more favorable option for our members. The diversity of the provider network is key to member engagement. Providers that are culturally appropriate and able to speak the language will be much more successful in engaging and retaining members. New digital solutions are out there in the market. The ability to reduce barriers to new solutions by providers, members, and community agencies will be essential to define and identify member needs. One example is a closed-loop referral system with a community-based organization, a health plan, and a provider to meet member needs. Encouraging providers to use Z codes, Z55 through 65, will provide more meaningful data to better understand populations and the effects of the social determinants of health. Having the ability to submit Z codes as encounters may help to quantify and support resources. Using this additional information can further support member risk and quantify an enhanced risk adjustment score. These are just a few things to think about. So the variety of challenges can impact overall prioritization. Next slide, John. So when considering offering additional benefits to members, determine the outcome or goal you're looking to achieve. If, for example, improving preventative visits is your goal, identify what the barriers are to achieving member compliance. If an incentive is what you have determined would improve compliance, what is the percentage compliance needed to recognize your return on investment? Will this strategy give you more information to support additional member risk? Will it help achieve better HEDIS scores? And/or will it support state pay-for-performance programs? We frequently started with a small pilot program at our health plan, and if effective, we increased the population. Enlisting members to participate in their own health can be tricky, as we know. Gathering information on the population through focus group surveys and any other method you know may work with your unique population. Crucial information to gather should include social determinant needs, the member's literacy level, and how they prefer to receive information. Once you have the basic information, you can obtain an assessment and close care gaps, for example. Provider staffing shortages continue to emerge. Rural areas are exceptionally challenged. Diverse providers and staff are needed to engage and develop trust with members. Community-based organizations can be utilized to mitigate provider and staffing shortages when partnering to solve member healthcare and resource needs. You may also determine an incentive can support a provider that is struggling with resources to assist with reporting Z codes, assisting with closing care gaps, completing lengthy assessments, or sharing important member data. Regardless of the approach, in order to be successful, technology, data, and measurement are key to any initiative or strategy and should be considered when implementing a program or initiative, so you are able to understand if you have actually achieved the goal or outcome that you intended. I think it's over to you, John.
Yep, thanks, Lynn. So apologize about the last polling question. Sorry for the technical difficulties. You were not allowed to select more than one answer, but good thing is this one's the same way. So where do you feel your plan needs to focus health equity and SDOH efforts? Poll should be launched. Okay, we're getting close to 50% in voting. This is always interesting for us because we kind of place bets on what is going to be the winner from a lot of these multiple choice questions. And it's always surprising when we look at the polling results. And I am not winning this one. Okay, about 10 more seconds and we'll close the poll. Alrighty, it looks like technology, data, and reporting capabilities was the big winner here at 40%. Surprisingly. All right, okay, so now I'm gonna go turn it back over to Jen, and she's gonna talk about the future. Jen?
Hello again, everybody. I'm going to go ahead and say that I am not surprised that it's technology, given that I am a big proponent of technology, and that's a lot of what I do. So it does seem like there are, what I'm finding just before we go into the future, and I don't know how many of you are faced with this, I'm finding this to be one of the areas where executives go to conferences and speak to somebody who's got a technology solution and they come back and want to implement it without really thinking through the end-to-end or, what the implications might be. So I think back several years ago, there's been waves of this where the, new hot topic and everybody goes and starts to buy, and there's a million different solutions out there. And sometimes it's really hard to figure out what is the right solution for you. And then the data and analytics piece is the flip side. And a lot of health plans that we talk to are really struggling to the data capture first off, as well as pulling it into your different reporting databases or data warehouse, and then accurately getting it into your analytics and how you can really leverage that information from an outcomes perspective. So my little soapbox there. So planning for the future. So John, if you can switch to the next page. One of the things that we think is really important is, from a health plan perspective, you've got to really think about where are you at in your journey, and don't overestimate where you're at in your journey, because that could put you to a big disadvantage. So you got to make sure that you're at the right level, and I guess the same could be said for underestimating where you're at. A lot of plans that I talk to kind of overestimate, and they think that they might be all set, but they're really back in the planning stage, or maybe just starting to execute their plan. So we thought it was important to kind of think about this and encourage you to think about it. We have another page that kind of talks about, is based on where you're at in your journey, what are some next steps that you can be doing or thinking about. So I know this is a little bit cliche. Someone that saw this said, oh, it's another one, but it's a good way to think about it. It's a good way to assess where you're at. So you're either planning, executing, assessing, which is your continuous improvement, and then evolving is, what's next. So if you're in that assessing phase and thinking towards evolving, you're in a great position. Most plans, however, that I'm working with or talking to are either in planning or executing. They're not much past that at this point. So if you are, hooray for you. Next page, John. So if you're really just starting out, you should be thinking about what is your vision. Think about where are you at, not only from a data perspective, but also from an organizational perspective. In order to be successful with health equity and achieving, breaking down those barriers of health disparities and really understanding SDOH, you need to make sure that your entire organization is well versed and speaks the same language. One of the other things that we find is health plans, may be pretty far advanced in the population health or certain quality areas, maybe clinical areas as well, but some of the administrative areas and customer service, eligibility processing, they're really quite a bit further behind. And so it's important that you do an organizational assessment and really make sure that you have a good picture and a plan for how to get everyone onto the same page. So, planning, you can complete a gap assessment, needs assessment, and then really start down your path. One of the things that you need to keep in mind is just when you think you have a good strategy and implementation plan, there's going to be a wrench thrown, and you're going to have to replan and adapt that to whatever, from a stakeholder perspective or a new challenge or a new technology that your CEO wants you to buy, whatever it is, you're going to have to be continuing to plan. From an executing perspective, you do need to have some kind of a governance strategy. And again, the road to health equity is a marathon and not a sprint. We're not seeing any indication that this is going to be solved in the next 3-5 years, maybe not even 10 years. It's continuing to evolve. It's been around for a long time. There's new tools and approaches and different strategies that we can take. But we're in it for the long term, and so we need to be approaching it that way. We need to make sure that there's flexible project management approaches, because like we said, every day you never know what's going to come up next and where you need to shift focus, just like a lot of other things that we're all working on. And if you are executing, one of your focus areas really must be related to member, provider, and community partner engagement strategies. Without clearly defined engagement strategies, you will struggle to be able to monitor, much less achieve health equity. So that's a key piece as you're approaching your planning and moving really towards executing. From an assessing perspective, this is where Lynn said one of the things at the plan that she worked with previously, they did a lot of assessing as they went, and they took a pilot approach where they tried it small and they tried a very, well-defined approach, see if it works. If it works, let's see how to expand it. And if we need to tweak it, let's evaluate how to tweak it. That's a good lesson that's learned from a lot of different approaches and implementations. But here, because it's always evolving, it's a really good thought process to take. And then, next, you also need to be thinking about the financial impacts, because if you're spending $10 million and you start achieving health equity, but it's really not getting you to the point, you may be not investing your money in the way that you should in order to really get the gains in terms of health equity outcomes and overall measurements of success that you're really looking for. So you should always, again, continuous improvement, looking for how do you make adjustments based on your experience to date, as well as the curveballs that are being thrown to you on a most likely pretty regular basis. And then if you are evolving, hopefully you get to the point where your governance approach is in place. You've got a team that's regularly monitoring. You've got a way to look from an analytics perspective, and then you can take in new requirements from a program perspective, or new accreditation requirements, or new CMS requirements, whatever it is, and you can get to the point that you're maintaining effectivity within the programs that you've established while still moving forward and continuing to evolve with the next challenge and the next challenge. So, we think this is a good place to start in terms of evaluating where you're at and what your opportunities are. Hopefully, this is helpful for you as well. So John, do you want to pop over to the next polling question?
Yep. Thanks, Jen. All right. Where is your organization at in its health equity journey? And we're using those 4 categories that Jen just went over: planning, executing, assessing, and evolving. You must have done a good job explaining these, Jen, because the voting is coming a lot quicker this time around. All right, about half of you had voted, so we'll keep it open for a little bit longer. All right, a few more seconds and we'll close this one. Okay, it looks like the majority are in the planning phase. And again, these results will be shared with the deck. All right, so I'm going to turn it back over to Jen, and she's going to talk about how ATTAC Consulting Group can help.
Hi again, everybody. So we're going to, take a minute just to talk through some of the things that we provide assistance for, and it should be things that you should be thinking about within your own organization. How are you supporting? So first off, program and project management. This is the type of project or program or approach that you really need to be thinking about supporting the governance structure with a strong program approach, so that you can evaluate risks, so that you can evaluate scope, so that you can make sure that your pilots are well defined, and so that you're evaluating the outcomes and really keeping that continuous improvement approach going. So next, John. So, next we've got technology solutions. We've talked about this several times. There are all kinds of technology solutions, and lots of them are overlapping. Lots of them are pretending to be, or talking about being, I can't say pretending, talking about being full scope end-to-end population health solutions. But you have to keep in mind, you need solutions within your core systems as well. You need to make sure that it's embedded throughout your data warehouse and analytics, and not just bolting on to your portals or your apps or different outreach applications and partnering with vendors who may be doing things to be able to try to help. There are also technology solutions coming out more and more to help with community partnerships and closed loop referrals with SDOH, so that if, for instance, someone needs a referral to a food bank, you actually get the handshake back that person went to the food bank, so that you don't need to question whether or not that was achieved. So lots of different technology solutions out there. There's zillions of them, and you need a good way to be able to evaluate which one is best, or most likely multiple. Some clients that we're working with have 10 or 12 different vendors that are all working at different pieces of the puzzle to be able to try and get and start really working through this. Next.
Yeah, Jen, before we move to the next one, to your last point,
Yep.
we've been asked to evaluate, like Jennifer just said, there's lots of pieces, and one of the clients was using about a dozen. We've asked several times to evaluate vendors and their technology just from an assessment perspective. We're vendor agnostic, but we'll definitely give our assessment of the value they bring, and more importantly, the value that they're getting. If you're not utilizing something, maybe 10, 15% of what they actually can do, that's going to be huge for them. So we've been asked several times to evaluate technology solutions, particularly since Jen mentioned there tend to be a lot of vendors out there and a lot of solutions.
Thanks, John. So again, we've talked about data capture, reporting, and analytics a few times. Data capture on the SDOH side, I find to be more and more, and Lynn used it, race and ethnicity, probably the two easiest things we think about, but from a data capture perspective, all kinds of challenges there. Some systems only have one field for both of those. Every single regulatory entity that's out there uses their own set of standards. So there is no real industry-wide standard for race and ethnicity, even though there are several purported to be out there. So that even the simplest, the most long-standing data sets can be very, very challenging overall. And when you add on the fact that your government programs tracking from what your state or federal partner has sent you, you also need to take into account what about member self-reported data, because that's usually they're going to be okay maybe telling you or telling their pharmacy. They may not be okay telling the federal government or the state or calling to make that update. So those are all different kinds of things that add all kinds of challenges to being able to just do data capture, much less get it into reporting and pull it through to analytics. Next, John. We do have quite a bit of experience with benefit services and program design, especially in, kind of supplemental benefits and how to pair benefits and rewards and incentives from a member perspective. And we have experience with helping you design them, but then also get them implemented appropriately all the way through to encounter reporting and being able to capture it into your HEDIS or NCQA results and things like that. Next. We do have a pretty strong member and provider engagement processes, support, as well as education and tools. So we're working with lots of clients now to be able to make sure that we're making the most of member and provider engagement opportunities, both, mostly self-service, quite frankly, because you want to try and get to self-service, but really making sure that you balance self-service versus when you should be, providing a helping hand, one-on-one. Next. And then lastly, network development and value-based contracting. One of the things that we know is every plan that we speak to has some level of network adequacy or access issues that they're dealing with, and particular strategies around SDOH, like with transportation, like with telehealth opportunities. Those kinds of things always can be considered. And lastly, from a value-based contracting perspective, we're seeing more and more value-based contracting in non-traditional approaches. So your claims-based providers, there's lots still going on with evolving value-based contracting. We're starting to see more and more with community-based providers, with delegated care coordination providers, and what strategies could be employed there. So there's a lot happening overall. We think that we're pretty well positioned, and we'd love to be able to have a chance to talk with you as you continue down your journey. So John, turning it back over to you.
All right, thanks, Jen. So we've come to the question section, and I've got several questions in the control panel. And again, if you have a question, feel free to load it into the questions section or the chat section on your control panel. Okay, so I'm going to read the question, and then our speakers are going to answer. The first question is, do you foresee the use of Z codes will become a requirement with possible penalties for not utilizing them?
Lynn, do you want to take that one, or do you want me to?
I mean, sure, I can take a stab at it, Jen, and then if you have things to add. I do not think that there will be penalties for not using Z codes. However, I think that we will be seeing more prioritization around Z codes and how they can be utilized, because well, and states may require it. I don't know that there would be any, monetary or penalties around it, but I think they will be encouraged as we move into the future, because they can provide information like nothing other on the claim that is related to a social determinant.
Okay, great.
Thanks, Lynn. The only other thing I would add is, as of right now, we're not seeing movement at the federal or from what we've seen individual state level to make these fields required. But again, they're pretty new. The focus is pretty new, so we're not going to be surprised if that changes over time. John?
Okay, great. All right, and the next one is also around Z codes. It says, how do you incent providers to use Z codes?
Jen, do you want to take that, or do you want me to?
You can if you want.
So my experience has been, what we started doing was adding Z code requirements to some value-based contracting, just to see if that would help us get some additional information on our members. I think if you give providers, because providers aren't reimbursed for Z codes, if you give them a little bit of a bump as far as paying them a little bit additionally, because this is not something that's worked into their workflow, I think it might you might be in a better place with your providers, and they'd be more willing to do it for you.
Okay, thanks, Lynn. The next one is, what is the best way to work with providers around health equity?
So I'll start on this one, Jen, and then if you want to provide your input as well. I personally think that collaborative relationships with providers go a long way. And if you sit down with your providers and really talk about, this is what I'm trying to achieve, these are some of the state requirements, NCQA requirements, how can we work together, what is it that you need? There's many examples. You could put one of your staff members in the provider office to assist. You could make phone calls for the providers. There's so many things that you could do, but I think the key is a collaborative relationship versus just saying, I'm sending you a file with members that are assigned to you and they're in your panel. So I think, how can you achieve that collaboration with your providers? I think that goes a long way, because as we know, providers are very stretched. Their resources are tight, and many of them don't have advanced technology to achieve the results that we may expect or need.
Okay, thanks, Lynn. Another one around Z codes. If there are no consequences to using Z codes, what would be the point? Is it just more information stored?
Well, I think it helps to identify your population and the needs of your population. So because you will get lots of social determinant information, you may better identify your member risk and have the opportunity to act on that information. So, right, there is no, requirement at this time, but if you can work with your providers to get that information on your claims, it will just be so much easier than trying to obtain it in other ways.
Okay, great.
Yeah, I think oh, John, sorry. I think the other thing to think about when you're working with your providers, it is really easy to say it's extra work. What we are going to see again is Z codes are fairly new. They're being introduced, they're being phased in. We do expect that the Z codes are going to become more and more and more a part of encounters and risk adjustment. And, so over time, we're going to need to all be reflective and flexible and adaptable. And right now, the impacts of Z codes and getting them onto claims is probably not going to be the same as even a year from now. I expect that we're going to see, different kinds of incentives and approaches, and those Z codes are going to be critical to some of the CMS requirements, the HEDIS requirements, and NCQA review of information, because it's really a primary source for how you can get supplemental information about SDOH and other health equity related, conditions and everything into your data set. So it's going to be more and more important, even if it is not a required field on the 837.
Okay, great, thanks. Yep, next one. Can you talk a little about building a CBO network to address SDOH requirements?
Sure. So, Lynn, do you want to start or do you want me to take that one?
You can take that one, and then I can share my experience with one CBO that we worked with.
Yeah, so I think a lot of plans historically have built their own kind of local networks of CBOs and even community resources that are not CBO based. And that's been to various degrees of success. What you need to do if you're doing it on your own is you really need to have a strong collaboration, as Lynn said, with your provider community, and also with any delegated care coordination entities or even state partners or other partners out in the communities. That's what's critical. So you need a community workforce to be able to do that kind of growth and development. The other challenge that happens is, how do you share it across all the different providers and folks who are working with your members, and even to your member community at large? So, what has been evolving over time is there are several vendors. Again, we're vendor agnostic, so we're not going to say the names of any vendors, but there are vendors out there who can help you if you have your own network, build it, document it, and get it out to your provider community and potentially your member community. There are other organizations and vendors who will not only provide the technical support, but they'll also work with you to build a CBO network. It's less likely that they're going to be able to get in to more of the community resources, but that could be an option. And we're starting to see states or local communities even do that, so that it's not health plan sponsored, but rather at the state or city level, they're building these networks of CBOs to be able to make sure that people have access to the resources that they need. Lynn?
I was just going to share an example of starting small in a pilot. We actually opened an office at a community-based organization, and they really wanted us to be there, and it has turned out to be so successful, not only engaging our members, but helping to engage members with resources of the community-based organization, and offering things from our perspective that the community-based organization wasn't. And so it ended up to be a great partnership between the community-based organization, us as a health plan, And then we could include the providers in their support as well. So it's working out well. We started small, but there's definitely opportunity.
Okay, great, thanks. Next question. What characteristics and strengths in COS should health plans prioritize when considering community network support around SDOH work? It's kind of a long one, so I'll say it again.
Thank you.
What characteristics and strengths in COS should health plans prioritize when considering community network support around SDOH work?
Lynn, do you want to start or do you want me to take this one?
You can start on this one, Jen.
So if we're talking about, characteristics and skills, when you think about your internal team, you again, I think that you really need to have a community outreach program that includes, from a strong, quality and clinical focus. But you need people who are really capable, engaging, and that are comfortable going out and that are actually in the community. You're less likely to be successful if you have people at a corporate office who are continuing to try to get in the weeds in your communities to be able to build those relationships and continue to foster the types of collaboration that you need. What we see pretty consistently is that you may have some level of corporate, focus and orchestration, but success is really going to be very dependent on having those people boots on the ground in your community, engaging as much as you can to be able to build relationships and make sure that it's collaborative with your provider community as well. The other thing I think some people have started to leverage is even engaging from a member perspective and getting feedback from members on what they know. So being able to do some member type of outreach or taking advantage of member focus groups and things that you may already have in place. But again, I think the key thing is that you have people who are confident and engaged and that you get boots on the ground inside the communities that you're building. I think to Lynn's point as well, a lot of organizations that we've been seeing successfully start out with targeted areas where they know that there is a need and they know that they have a resource who can go in and is comfortable in that kind of capacity. So Lynn, any other words of wisdom there or thoughts?
No, I totally agree with you. Jen, we found that members or staff from the community that were trying to connect with the community and the members were so much more successful than anyone else. That trust that they developed with members really helped us to achieve engagement and then improve outcomes for those members.
Okay, great. All right, thank you both. And this concludes our questions. And I'm going to turn it back over to Garrett to close us out.
All right. Well, thank you all so much. This was a fantastic presentation, and I wanted to apologize for the technical difficulties we had with some of the polling questions. I know those were supposed to be multiple choice, so we will follow up via email afterwards, and maybe we'll send a survey out or something. But thank you all so much for joining us. I wanted to really quickly, as we're closing out, to encourage you to visit bbcexhibithall.com and check out the ATTAC Consulting Group virtual booth that they have there. This is a really cool place that you can interact with the team and do a little deeper dive onto what they're doing in the value-based care space and contact them as well. So yeah, please check that out. And then finally, if you want to reach out to the team, feel free to do so. We've got, John, if I could have you go to the final slide there. There we go. So their contact information is below. You can reach them at their website, or feel free to reach out to me as well. I'm happy to facilitate an introduction, and our speaker's information is in the slide deck, which we will be providing everybody. So after the webinar is done, in a couple hours, you will receive an email that will have a link to the to the recording as well as to where you can download the slides. So finally, again, thank you so much for joining us. We really appreciate your time today. Hope you have a wonderful rest of your day. Thank you so much. Bye-bye.